Thank you, sir, and thank you to the organizers. I'll be discussing the role of driver oncogenes in patients treated with the Pacific protocol. And this was published in JAMA, and this was done by the MD Anderson group. So we know that the Pacific trial has changed things in stage 3 unresectable lung cancer with an improvement in PFS and OS. But the role of driver mutations, especially EGFR, ALK-ROS, and KRAS, is currently uncertain. The Pacific trial did include patients with EGFR mutations, but there are reports that they did not do so good. 6% of the population had EGFR, but since there were a lot of squamous cell cancers in the Pacific trial, many of these patients were not tested as well. So this study was done in MD Anderson, and it was a retrospective cohort analysis over 3 years, and they included patients with unresectable stage 3 non-small cell lung cancer who completed chemoradiation, and there were 104 patients who were included in this study. They all received durvalumab at least one cycle, and which was continued for 12 months, and this was after that, these patients were subgrouped according to their presence or absence of driver mutations. And also another grouping was done comparing KRAS and non-KRAS variations. The reason why KRAS was looked for is because there have been reports that KRAS mutations are more sensitive to immunotherapy. So the study outcomes was progression-free survival, which was defined, which was considered after the date of chemoradiation completion, until recurrence, death, or any other cause. Overall survival and PFS2, that is progression after the duration of time the patient before the second progression was also studied. So coming to the results, you had 104 patients, of which 2/3 did not have any driver mutations. Around 15% had non-KRAS driver mutations, and 15% had KRAS driver mutations. The other factors were more or less balanced between both arms. So these are the results, and as you can see, the first curve, that's number A, compares non-driver variation with driver variations, and you can see that patients without a driver mutation did much better than patients with driver variations. The difference is a little astronomical. You have 8.4 months PFS versus 40 months PFS, which was statistically significant. In the second curve, they looked at KRAS driver mutations specifically and checked whether immunotherapy worked better in that subpopulation. But here, surprisingly, it did not. It had low PFS of 8 months, and the other arm did 40 months, the non-driver mutations. And the third curve is the overall survival. And here also, a difference of 36 months versus not reached. As you can see, the separation of the curves. So if you did not have a driver mutation, the durvalumab worked pretty well in you. But if you had a driver mutation, you did not perform too good. Now this is the PFS2. And if you see the PFS2, it is reverse of what was previously discussed. The patients who had a non-KRAS driver mutation like EGFR, ALK, they had a better PFS2 compared to the other group. The reason is obviously because if you have a driver mutation, second line, you're going to use a TKI. And TKIs are going to work better than chemotherapy in the other arms. If you look at the KRAS driver mutations also, those patients, mostly we offer chemotherapy. They also did not do quite well for the PFS2. And PFS2 was improved in patients with EGFR, ALK-ROS mutations. Here's the difference in PFS, 13.7 months versus 4.4 months, and 13 versus 4 versus 4.4 months in KRAS driver mutations as well. Now, if you look at the toxicity, these are the common toxicities which you will face in patients post-chemoradiation and durvalumab. What of particular note is the rate of pneumonitis, which is surprisingly higher than what we saw in the Pacific trial. So if you remember in the previous, the speaker mentioned that grade 3 toxicity was in 3% in Pacific, whereas in the real world, in these patients, you had 16% pneumonitis, and grade 2 or higher pneumonitis was seen in 42%. That's almost 50% of your patients, you're going to face pneumonitis. So, you better keep those steroids ready for these patients. If you look at the driver variation, based on driver mutations, was there any difference in toxicity? No. You had equal amounts of toxicity in both groups as well. So the question is, why do these driver mutations do badly? One of the reasons is tumor mutational burden, because you have a single driver mutation. The TMB, the tumor mutational burden, is going to be on the lower side. And we have studies which have shown EGFR has markedly lower tumor mutational burden. And if you have low tumor mutational burden, obviously your immunotherapy mostly is not going to do well. Are there other studies which try to look at these subgroups, these EGFR mutated or driver mutation subgroups? There is a retrospective study which looked at patients who had EGFR mutated stage 3 non-small cell lung cancer, and some patients were given just TKIs in conjunction with CRT, and they compared this to patients who received the Pacific regimen, and they found the PFS was much better when you used an EGFR TKI, 26 months versus 10.3 months. You have ADAURA, which is post-surgery, you have a PFS benefit with osimertinib, and you have an ongoing LAURA study, which is looking at osimertinib in these EGFR mutated stage 3 unresectable non-small cell lung cancer after chemoradiation. So the results of that is going to be definitely interesting, but I expect it's going to be definitely positive. So the limitations of this is a small sample size of around 100 patients. This was done in MD Anderson, single institution, but I think that's pretty good. And it's got a short follow-up time with immature OS data as of now. So the authors concluded that it is important to assess every patient for your driver mutations prior to starting treatment, because that can change what you're going to offer the patient. In the future, you can replace or combine durvalumab with TKIs who have driver mutations. We don't know what would be the outcomes with that. The final slide, my take on this. Stage 3 unresectable lung cancer, look for driver mutations. If they have it, they have to be treated differently. Because the PFS in the FLORA was 18.9 months, Pacific was 16.9 months. It's a small difference, definitely. But if you look at PFS in the LX trial was 34.8 months, and Pacific was 16.9 months, that's a dramatic difference. So if you have an ALK mutation in stage 3, I think I would prefer definitely using a TKI over the durvalumab regimen. But yeah, it's each person to their own. And for EGFR, also mostly, I'm still going to use TKI, but Druva, it's almost similar, the PFS, but the final thing is driver mutations are going to make a difference, and we will have those data which is coming up, especially after the LAURA study. Thank you.